Our next presentation is going to be on syncope in children and adolescents by Dr. Miranda. And just as a reminder from this morning, Dr. Miranda is a pediatric cardiologist in Sanford, Fargo. He earned his medical degree from Universidad Iberoamericano in Santo Domingo and completed his residency at Cook County in Chicago and his fellowship at Rush. He's been here with us in North Dakota since 2016. Okay, thank you, Dr. Miranda. We're excited to hear from you.
Thank you very much, and I'm impressed with your accent, with the way you pronounced Iberoamericana. So I have no disclosures. I'm doing syncope. Basically, the goals here, I really wanted to focus on terminology. I believe that we can beef up our notes and how we look at syncope and pre-syncope through the terminology. I wanted to look at a little bit about incidents, a little bit about the important aspects of history of present illness or of syncope itself, physical exam and vital signs, and the types and role of testing. And so I wanted everybody to kind of, if you're going to focus on any part of this presentation, I think each terminology here, or each term here is very important. First one we're going to start off with is syncope, and this is probably the most simplest one, but syncope is a transient loss of consciousness associated with the inability to maintain postural tone. And the one thing I want to make clear is that it should be rapid and have spontaneous recovery. Somebody should not be out for 4 minutes, for instance. It should be within seconds. An absence of other clinical features alluding to another form of transient loss of consciousness is also part of this definition, such as pseudosyncope. And then to differentiate this from loss of consciousness is a cognitive state in which one lacks awareness of oneself and one's situation with an inability to respond to stimuli. An easy example is you hit your head really hard and obviously you lose consciousness, and most of the time a lot of time it's for more than just a few seconds with some sequelae after the loss of consciousness. Other terms that I think are important, and some we know, pre-syncope or near syncope, symptoms prior to syncope such as lightheadedness, visual sensations such as tunnel vision. A lot of this could be prodrome. Another term would be prodrome type symptoms prior to having syncope. And then the important terms here that I believe we should pay attention to is orthostatic intolerance. These are the actual symptoms such as lightheadedness, palpitations, tremulousness, general weakness, and blurred vision than one would get when going from a laying or seated to standing position, going upstairs, having a hot shower, things of that nature. Orthostatic tachycardia, again, from a laying to standing position, is defined as a heart rate of more than or equal to 40 beats per minute between the ages of 12 and 19, or 30 beats per minute otherwise, within 10 minutes of moving from a recumbent to a quiet standing position. And so remember those two, because we're going to come back to that. Orthostatic hypotension, this is another important one for everybody to kind of memorize. It's a drop in systolic blood pressure of more than or equal to 20 millimeters of mercury, or a diastolic blood pressure of more than or equal to 10 millimeters of mercury with the assumption of an upright posture. There are several types of orthostatic hypotension that we should all pay attention to. There's the immediate type, so basically a transient decrease in blood pressure within 15 seconds of standing with pre-syncope or syncopal type symptoms. There's a classic type that's within the 3 minutes of standing, again, with the same definition of the blood pressure measurements seen above. And there's a delayed type, which is an interesting type where a patient can go from a seated to standing position, not really feel any symptoms or have any drop in blood pressure, but then after 3 minutes of being upright, they start to develop a drop in blood pressure. And there's a more elusive neurogenic type, which is secondary to a dysfunction of our autonomic nervous system, kind of more associated with dysautonomia or POTS. Cardiac syncope, this one's very easy. Cardiac syncope is secondary to a cardiac cause, and Dr. Horner had alluded to before, it's never the heart except for this terminology, cardiac syncope, where intrinsically, electrically, your heart's causing bradycardia, therefore a limit in cardiac output, or tachycardia for this, with a limit in cardiac output, or you have hypotension due to cardiac output itself. Maybe the function of your heart is not adequate. You could have obstruction, like severe aortic stenosis, for instance. You could also have vasodilation or even dissection of some major artery. And then you have non-cardiac symptoms, which pediatricians are quite aware of. Reflex syncope, which we'll go through in a second, but obviously volume depletion, which includes dehydration and blood loss. So the one syncopal term here that you guys are all pretty aware of is the reflex syncope, more common being vasovagal syncope. It's syncope due to a reflex that causes vasodilation, bradycardia, or both. It's the most common form in terms of vasovagal. May occur during standing, seated, or secondary stress or pain, but commonly in the pediatric setting, just drawing blood could possibly cause a vasovagal type syncope. And it's usually followed by some level of fatigue. Situational syncope, which is, I find it funny every time I read this, but is associated with a specific action, such as coughing, laughing, swallowing, urinating, or defecating. So it's, I've not seen this, but it wouldn't be too good if every time you coughed, you passed out. Postural tachycardia syndrome. This word gets thrown out often, but this has a specific definition to it that we should all pay attention to. So it's called POTS. It's orthostatic symptoms, which we had discussed previously. Your orthostatic symptoms are lightheadedness, palpitation, blurred vision, fatigue. But then you also have to do your due diligence in looking at the heart rate, specifically from a seated to standing position. Again, those defined by the 2017 ACC/AHA guidelines as a heart rate between the ages of 12 to 19, a heart rate of more than or equal to 40 beats per minute, or otherwise more than 30 beats per minute. Or if you stand the patient up and they have a heart rate kind of at baseline of 120 beats per minute while they're calm. And then it's also defined as an absence of orthostatic hypotension when you get them upright. The incidence of syncope, about 15 to 50% of them you're going to see within our age group, so adolescents or young adults. 80% are due to neurally mediated syncope or vasovagal. And again, the term, it's usually not the heart, it applies here. 1.5 to 5% have an actual cardiac cause associated with them, but this is probably the most important thing to rule out. Breath holding.
Anything in a long time.
Huh?
And he's also getting infusions. I think.
Oh, somebody's talking, so if you want to mute your.
He's harder to break than he used to be. And so.
Somebody's.
Give me a holler, but.
Oh, I'll just wait.
Hopefully he's not broken.
Sorry, Dr. Miranda. Can everyone please mute?
Yeah, well, depending upon what it is, Dr.
Are you able, Dr. Conrad?
Okay.
Okay.
So I'll just risk. Okay. So then, breath holding spells occur in 1 to 3% of toddlers, and pediatricians are very good at just noticing those as well, distinguishing those from syncope itself. Okay, so this is kind of like the meat of my presentation. I think Dr. Anderson had alluded to this before, but history. You got to take a good history. If not, you're going to miss things for sure. And on the left side here is our list of red flags, and I'll go through those first. But a patient who comes in with syncope, and you ask them, did you feel anything prior to the syncope? Did you feel lightheadedness? Did you feel tunnel vision? A lot of patients will tell you if they felt it. If they had no prodrome, that's a red flag. Palpitations preceding loss of consciousness. A little bit harder of a question for the patient, but if they have clear history of palpitations and or they had significant palpitations which led to the syncopal episode, that's a red flag. Exertional syncope is always a red flag, and that's always a question that you should be asking. What were you doing at the time where you had syncope? Were you running? Were you playing? If that's the case, that's a red flag. Structural heart disease, again, is something always to raise an eyebrow to, and should be something that with a pediatric cardiologist should evaluate, especially in the setting of syncope. Heart failure, the easiest one here is, especially with a history of a patient with a history of or a lack of history of anything significant from a family perspective, would be maybe a viral illness that led to possible myocarditis leading to heart failure. And so having that history at hand, knowing that they didn't have a viral illness 2 or 3 weeks prior, and seeing whether or not there's symptoms that developed since the viral illness could lead to a diagnosis of heart failure, and therefore that's a red flag, especially when associated with syncope. Cerebrovascular disease isn't more of an adult concern, but some kids can develop stroke secondary to clots that can pass through the heart. Family history, big deal. Your family history has to be spot on. You have to ask about parents, but importantly, you have to ask about uncles, grandparents, and things of that nature, even siblings. But anybody who's passed away, a lot of times what families are going to tell you is like, oh, his grandpa or his grandma passed away at 45, but she had really bad diabetes. That's still a red flag. He was a smoker, she was a smoker. That's still a red flag if they passed away early on in life. People usually don't pass away from smoking at 40 years of age, for instance. Okay. And trauma is something that is going to be probably obvious when you see them in clinic, or if you see them in clinic. And so these questions are very important. And I won't reiterate on anything on the right, because I think we've kind of reviewed that from looking at the list. So again, physical examination. I'm going to harp a little bit on orthostatic vitals. I'm going to say that before any pediatrician sees their patient, ideally, what they should ask for is orthostatic vitals for patients with syncope. It's going to help you. Lying, sitting, standing, and ideally after 3 minutes upright, but at least lying, sitting, and standing, you should have heart rate and blood pressure on all three. They're very helpful in assessing whether or not you see a significant increase in heart rate, alluding to one of the definitions that we had previously spoken about, or a drop in blood pressure, alluding to one of the definitions we had previously spoke about. Obviously, you're going to assess the heart rate or assess the heart rhythm. An abnormal rhythm should prompt an EKG, unless you're associating it with sinus arrhythmia. Murmurs, gallops, and rubs should prompt an EKG and possibly an echocardiogram if the murmurs are pathological. If you hear gallop, obviously that alludes to heart failure, and rubs allude to pericardial effusion. Assess neurological examination for focal deficits as well. So when is an EKG useful? Again, it's a class 1 indication, so you're always able to get an EKG. And if your concern is anything more than vasovagal, you should get an EKG, in my opinion. ECGs are widely available, inexpensive, and can provide information about potential and specific causes of syncopal episode. What you're looking for and what you're kind of waiting to hear from pediatric cardiologists about is, is there anything significant, if you see bradyarrhythmia, is there anything significant we should be concerned about? Is there a conduction block? So if you have first degree, second degree heart block, or even third degree heart block, that would be concerning. Are there sinus pauses? Again, a bit unusual to see it on EKG, but if it's there, it's important, and we should figure it out. And EKG can also demonstrate arrhythmogenic substrate for syncope or sudden cardiac death. So for instance, we can see from an EKG, as previously mentioned, whether there's pre-excitation alluding to the palpitations the patient may or may not have complained about. We could also see things that can cause sudden cardiac death, like Brugada, lung QT syndrome. So those are channelopathies. And so that's possible as well. Although the absence of those things do not mean the patient does not have those things. Hypertrophic cardiomyopathy, again, somebody with an EKG that's demonstrating significant left ventricular hypertrophy, or alluding to significant left ventricular hypertrophy, for instance, would or abnormal Q waves would lead to probably an echocardiogram thereafter and a cardiology visit. And arrhythmogenic right ventricular cardiomyopathy, something that is more common in other countries, but something we should be aware of here in the United States. And obviously ectopy, so atrial or ventricular ectopy, extra heartbeats on EKG, that's something that can be helpful as well. Cardiac imaging, again, I think Dr. Horner did a good job in demonstrating that we should be very thoughtful when we're thinking about cardiac imaging, because it's an expensive test. But it's a class 2A indication, and it's specifically geared towards your exam, or the history. If the history is telling you there's congenital heart disease associated with syncope, you want to get an echo, that seems to be appropriate. If your exam is alluding to a significant murmur, get an echo. If your family history is alluding to sudden death, or there's cardiomyopathy in the family, and or again, significant murmur that may allude to, or an EKG allude to cardiomyopathy, get an echo. So suspected heart failure, and when in doubt, in my opinion, obviously any exertional syncope in my book, you get an echo. You get an EKG and an echo. And the one thing I'm looking at with kids, I'm not looking for coronary artery disease. I'm looking for abnormal coronary arteries or an abnormally structured or functioning heart. Stress testing is more of a recommendation that as a cardiologist we would do. Based on the 2017 guidelines, they look at stress testing as a class 2A for those that have exertional syncope. I would say, I would have a few caveats to this. When it comes to somebody who clearly has structural heart disease that may increase a risk for syncope and has a syncopal episode, I'm not going to necessarily need an exercise stress test to prove that the patient had the syncopal episode secondary to those same things. But there are certain anomalies, like certain coronary anomalies, that aren't absolute indications for surgery that may need exercise stress tests to see what the importance, or at least an exercise stress echo, to see the importance of it. Long QT syndrome, ever since I was hired here, I had a great conversation with Dr. Horner, who did a study in 2012, I believe, on the indication for stress testing and diagnosing, or to help diagnose long QT syndrome, and I've been using it ever since. And basically, we would take patients who maybe have borderline long QT on EKG, maybe a borderline history, take them to the stress test, and see whether or not during recovery they have progression of QTC, and it's been quite helpful. And so it's a lot better, a more surgical way of diagnosing these patients prior to considering genetic testing. And then the other entity here is PVCs and the concern for catecholaminergic polymorphic ventricular tachycardia, or CPVT. And so the concern here is if you have a patient who has significant PVCs, basically extra heartbeats from the bottom of the heart, you would stress them to see whether or not those PVCs go away. If they don't go away or they get worse as they are running, that could be a concern for CPVT. We already kind of spoken about cardiac monitoring as it pertains to Holters and event monitors, and pediatricians are welcome. It's a class 1 indication, especially if there are concerns for palpitations. But again, you use the Holter when you see there are frequent symptoms, enough so that you could probably catch what you're wanting to catch within 24 to 72 hours. And you use the event monitor when the symptoms in terms of time frame are a bit more elusive, or maybe they're every other week or weekly or once a month, because it allows you to record for a longer period of time. And I think we've already reviewed those. So. And then when in doubt, there's a list here that I'll invite you just to go through personally, but when in doubt, that's a class 1 indication to consider in-hospital telemetry. If you don't feel comfortable as a pediatrician with a syncopal episode, which is an important, very objective complaint, then there's no doubt that you can consider either A, speaking to a cardiologist about the case, or B, observing the patient overnight to see if there's anything significant that may require telemetry, for instance. And so there's a list here that I invite you to go through that may be on your differential, for which you'd want the patient to either be in the hospital or speak to a cardiologist about. And so at the end of the day, what you're trying to do is assess whether or not this patient can go home and be okay, or needs further workup. Your initial evaluation includes a really good history. You want all the details. Physical examination, again, I harped a little bit on the vital signs, but the physical exam is very important. And then when in doubt, do an EKG, obviously in all patients, unless you're absolutely sure this is a vasovagal event. And if your initial evaluation is pretty clear that this kiddo's okay, then you can send them home. If it's unclear, then our due diligence to be honest about that and figure things out. If the patient's pale, for instance, maybe has had diarrhea, maybe they're volume down. But if the patient's complaining of palpitations, for instance, or has some type of orthostatic symptoms, then maybe you need to either give boluses of fluid, or you possibly need to recommend more fluid at home. But either way, if the complaints and/or findings are more significant than just orthostatic findings and the ones previously mentioned, then you have a slew of things you can do. You obviously can talk to cardiology. You obviously can, inpatient services are there for your help. And then we can decide from a cardiology standpoint whether or not the patients need stress testing, an echocardiogram, electrophysiologist, and or even in cases of, let's say, myocarditis, MRI or CT. This is just, and you can go, you can use this in your practice, but in general, this is just orthostatic hypotension, how I take care of it, how usually I think we all take care of it, but we recommend plenty of fluid. I've been told 80 to 120 ounces of fluid for an adolescent would be adequate to maintain volume per day, especially if they have significant orthostatic symptoms. And I use salt tablets in my practice, and I think it's one of the most objective ways to give salt. I think it's a little elusive to you to tell a kid to add salt to their diet. And salt tablets, whether it works or not, at least you know they're taking the tablet, and 1 or 2 tablets a day, and objectively them telling you they feel a lot better is of significant value to basically to the diagnosis and treatment of these patients. So that's basically it. I wanted to finish off with a couple quick questions, and I'll have the answers to these questions as well. But in a patient reporting syncopal episode, which of the following features would prompt hospitalization and or intense workup? And here, the answer is always going to be from this list, exertional syncope. Syncope upon standing could be orthostatic. History of again, this is a simple question. There's a lot of details that are missing, but history of pre-syncope could just be orthostatic. Family history of bicuspid valve is really non-specific to the syncope itself, but may merit an echocardiogram, for instance. A 14-year-old presents after 2 episodes of syncope upon standing in the past week. Both episodes occur after getting out of bed, short-lived, without sequelae. There's no significant family history of sudden death and no significant history prior to these episodes. I'm basically telling you that this is just a one-off. And what could you potentially consider if you're still nervous about the syncopal episode? And here, the best test you can consider is an EKG. It's a class 1. You can always do an EKG when in doubt. Last but not least, this one's a little trickier. A 14-year-old boy is seen for a sports pre-participation evaluation for soccer, not done by a chiropractor. He had an episode of syncope 1 week prior, which prompted his evaluation. It occurred after quickly standing from a seated position. He has a history of mild asthma and shortness of breath during exercise, which can be prevented using albuterol. His maternal grandfather passed from a heart attack at 59 years of age. He does admit to significant stress in the past year as his older sister drowned while swimming competitively 6 months ago. On exam, he is noted to have a 2 out of 6 vibratory murmur at the left lower sternal border, which is more prominent when supine. Which of the following features of his exam and history is most concerning and likely requires further follow-up? Anybody want to answer that one? That one I'll leave for you guys to answer. No?
Be concerned about his sister's death. If she drowned during a race.
I try to confuse you here with a few extra things, but the murmur is normal. The grandfather passed away is 59 years of age. And again, if you don't take a good enough, this is just a question to allude to, a good enough history will lead you to the right answer. At least you were saying 75%, but I would say, between 75 to 100% of the time. Testing is only as good as your physical examination and your history taking. That's all I got for you guys.
What was that? The sister's death?
Sister's death, yeah.
Okay.
That's not a good sign.
Yeah.
Yeah.
Competitive soon.
Thanks so much, Dr. Miranda. That was a great review of, do you guys, I do have a question regarding orthostatic vitals. Do you have a good resource for teaching nurses or for teaching your staff, like a refresher on obtaining? I know it's not complicated, but it's not something that I find is being done in like urgent care or walk-in clinics very often when this complaint is the reason for presentation.
Yeah, in my opinion, I agree with that, and I don't think, well, we do it here in our clinic, obviously, but I think it's underutilized, and that's why I kind of made it kind of like some major meat of my presentation. As far as a resource, is there anything out there that you've taught Candy, our nurse? Can Candy reach out to, can I have my nurse reach out to your team to see whether or not she can give you kind of our protocol as to how we do orthostatic vitals?
Sure, that would be great. You know, really, we have about 50 people in this virtual room. I guess with you guys, like 55 people, but you know, most of the children in our state are being cared for by people who are not pediatricians and probably by people who are not in this virtual room. So part of, you know, what I'm thinking about with asking you for these resources is, are there things that we can easily distribute to people who are seeing children within our state then that can help to improve the care that we're providing to kids across the state? That's really where these questions are coming from.
And I would say that maybe what we need to do is, when it comes to vitals prior to syncope, have a one-page instruction as to how to do this and then distribute that accordingly from our perspective.
That sounds great.
Okay,
yeah.
Perfect. Anything you'd like to add, Dr. Horner, Dr. Travis?
I think, Kathy, the only other thing that I would add to the syncope is he talked about those weird things that cause syncope, and one of those is hair grooming syncope. It sounds really funny, but it's a real deal. It's vasovagal, but it's typically a lady or a girl with long hair, and somebody's doing their hair from behind, whether they're ironing it, combing it, or what have you, and they're standing there, and mom's doing their hair, and they go out. Very common vasovagal, or commonly for a boy, he might be getting the back of his head zipped, really trimmed up, really nice and tight, and they will have a fainting episode. If you hear that in the history, 100% vasovagal, pretty much, unless they say, well, I was having chest pain and palpitations beforehand, but that's likely not in that type of history.
Okay, that's great. Thank you for highlighting that. I did also have a question when we were all on lunch after the last presentation. There was a question, how long can an implantable monitor last, and what are the indications for removal?
So 2 to 3 years is how long it can last. I know I have not placed an implantable monitor in my practice, but I think Dr. Brasher has.
Yep, I have a little boy with an implantable monitor. He's on his, he had for a year and had a few episodes. They're able to interrogate, after the episodes, the families will send in a transmission. We haven't been able to capture anything, so I suspect they're going to leave it in a little bit longer and then explant it, because every episode that he has had has been sinus rhythm normal. So I think it really depends on what they find. If EP, the electrophysiologist, can get the information they need, and then once they do, they'll explant it. Yeah. Oh, and Dr. Cannon's there.
The newest monitor that's come out will last up to 6 years. So you can do it through a little tiny incision about less than a centimeter long. You just inject it and then they go home. There's a home monitoring system that can actually call us every night and tell us if there's any events or anything else. But yeah, the old ones were 3 years, but the new ones are now 6 years.
And once the battery's dead, you should take it out, like you said. Don't leave it in.
Hey, that sounds good. And you touched on this a little bit, Dr. Miranda, and so did Dr. Cannon. I recently inherited a family of CPVT, that I think I share with a couple of you guys here, and was just wondering with regard to sports and physical activity, just in general recommendations, how that works after they're being medicated.
Dr. Cannon, I'll let you take this one as the expert.
Oh, so yeah, so the current recommendations are if they have no ectopy with exercise, then they can participate in all sports. But it'd be important to treat them with beta blocker and then repeat the testing to see if they could participate. We certainly do have athletes even playing college football with CPVT, but it is something that's very highly symptomatic, up to 80% by age 40. And so because of the high risk for sudden death, beta blockers are very important. But if they have no ectopy on a beta blocker or asymptomatic and just genetically positive, then they can play sports.